Good afternoon, good evening, good morning to everyone from different to the veterinarian, different region in the world who are joining from overseas to this Sri Lanka Veterinary Association third webinar series. In this third webinar series, we have organized 18 webinars in every Sunday at 1 p.m. We organize this webinar. And today, our resource person is Dr. Gayani Peiris, General Practitioner from Australia. And our moderator today is Dr. Gayani Peiris, Sri Lankan veterinarian. And without getting much time, I would like to invite Dr. Dilan Satarasinghe, the President of Sri Lanka Veterinary Association, to welcome you all. Dear President, over to you.
Thank you very much, Dr. Sugat, and the coordinator for webinar series. And also, I warmly welcome all the Sri Lanka Veterinary Association members and also international participants for accepting our invitation and joining to the webinar. Especially, I must thank Dr. Gayani Peiris. She has graduated from Sri Lanka Faculty of Veterinary Animal Science, and she has more than 15 years experience, and now she is practicing as a registered Australian Council veterinarians in Australia, and she is our resource person today. And also, she's going to talk on treatment and management of common eye problem in dogs and cats. It's a very timely needed topic to the small and companion animal medicine practitioners. Therefore, I think as SLVA, we thought that this is a very timely topic to be discussed today's program. I'm sure that all of you will have a fruitful session today. And as Dr. Sugat mentioned, our moderator is Dr. Gayani Peiris, Senior Lecturer and also veterinarian, belongs to Faculty of Allied Health Sciences, General Surgeon Kotalawala Defense University. Thank you, Dr. Gayani, as well, accepting our invitation to moderate the session. Over to you, Dr. Gayani. Thank you.
Thank you very much, Dr. Dilan and Dr. Sugat. Good morning, good afternoon, and good evening to all the audience around the world. So as the practitioners, we know that the eye conditions are quite common among small animals, and often diagnosing and treating these conditions are challenging to us. So that in order to share her knowledge and expertise on this topic on small animal eye conditions, we have our resource person, Dr. Gayani Peiris. So let me introduce our resource person to the audience first. So Dr. Gayani Peiris, she graduated from University of Peradeniya in 2007, and thereafter she practiced as a small animal veterinarian in Petret over 5 years. And then she migrated to Australia, and currently she is practicing as a small animal veterinarian in Melbourne. So that's her profile, and we are really grateful to have you here today in our platform in order to share your knowledge and expertise. So Dr. Gayani, the platform is yours in order to go ahead with your talk on treatment and management of common eye problems in dogs and cats. Over to you, Dr. Gayani.
Thank you very much. I'll try sharing the screen.
We can see your screen, Dr. Gayani.
Okay. Is it all good?
Yeah. It's all good.
Right. Thank you very much. And hi, everyone, and thanks for joining us today for this presentation. First of all, I should say that I'm not a specialist or an ophthalmologist. I'm a practicing veterinarian in Australia and would like to share my experiences and knowledge on the current treatment and management of common eye problems that we see in day-to-day in a vet practice. All righty. So the topics I'm going to discuss in my talk Keratoconjunctivitis, Keratoconjunctivitis, sicca, which is dry eyes, corneal ulceration, uveitis, glaucoma, cataract, and panels. Now, it's quite a bit important to have an accurate diagnosis for effective treatment. Otherwise, we end up doing. Sorry. Otherwise, we end up doing polypharmacy and can be unsuccessful and can impact on the outcome and the damage of the eye. So let's talk about canine conjunctivitis. So as you can see in the photo, you usually predominantly see conjunctival hyperemia, inflammation, edema, swelling, and thickening of the conjunctiva. Sometimes you might see blepharospasm and lacrimation. Now, there are a few causes for canine conjunctivitis. One is atopic conjunctivitis, which is mostly immune-mediated. And it could be secondary due to allergies. Follicular conjunctivitis is also another cause for the common conjunctivitis that we see. Sometimes we see bacterial or viral conjunctivitis. Now, it's always recommended to do a Schirmer-Tear test. It gives it's one of the diagnostic tools that we use. Now, if the Schirmer-Tear test is normal, it's commonly bacterial conjunctivitis, and however, if the conjunctivitis is long-standing and if still the STT is normal, you might want to consider allergies. Now, with allergic conjunctivitis, you usually see pruritus, so the dog might be wanting to itch the eye, you'd see point the eyes always, and it's most commonly bilateral. May see conjunctivitis with in conjunction with atopic dermatitis clinical signs, so an itchy dog with all the four paws red. Sometimes you might see a seasonality in the conjunctivitis, so you might get flare-ups in the summer or winter, and most likely they might have a mostly in the mornings you might see a bit of tearing and red eyes, which sort of resolves towards the latter part of the day. Now, sometimes these allergic conjunctivitis might respond with the treatment of atopy. Sometimes if it's in conjunction with food allergies, it might resolve with a change of diet. Sometimes all you might need is an antihistamine eye drop like Albalon. Now, viral conjunctivitis we don't see often in Australia because we are quite up to date with our vaccines, but it's also possible. So usually you see with distemper virus, herpes virus 1, and adenoviruses. In cats, if you see conjunctivitis in cats, it's mostly due to infectious cause, and mostly it's almost always either feline herpes virus or secondary to chlamydia. Now, if you look at bacterial conjunctivitis, the most common bacteria that end up causing conjunctivitis are Staphylococcus, Streptococcus, E. coli, Bacillus species, Proteus, and Pseudomonas. Now, sometimes you might also see conjunctivitis secondary to irritation. It could be mechanical, dust or smoke. Now, the owner might have a complaint. So yesterday we went to the beach and now our doggy's eyes are red. So they're most likely due to secondary irritation. So it's always recommended that we do a proper eye exam. So, and it's really important to try to think whether the clinical signs are primary or are they secondary to something else. So always examine both the eyes, and they do give you quite a bit of clues. Again, we do a Schirmer-Tear test, always check the tear production. This gives us clues whether it's secondary to conditions like dry eyes or is it mainly bacterial. And also it's always a good idea to check under the third eyelid. So you might have foreign bodies lodged under the third eyelid, which causes irritation every time the eye is closed and opened. Sometimes you might see tumors under the third eyelid. Now, checking under the third eyelid, you can even do in a consult room if it's a good patient who is cooperative. So you can use an alkane local anesthetic on the eye, and then lift the third eyelid and have a look, sneak peek inside. But if it's a fractious animal, you might want to do sedation or GA. And we almost always do a fluorescein test in all eye cases to check corneal health, whether there's any abbreviations or any ulcers on the cornea. Now, if the shear material is normal, most commonly, as I said before, it could be bacterial conjunctivitis. So then in those cases, you might want to start up a broad spectrum antibiotic. And with these cases, we tend to continue the eye ointment or the drops 24 to 48 hours post clearing, because there's always a chance that the clinical signs may be cleared, but the infectious pathogen might be still there. Now, if there's quite a bit of inflammation going on, you might want to combine the antibiotic with a steroid. So you can use either separately, or you can use an inbuilt steroid antibiotic eye ointment such as Amazine. Now, other diagnostic tests that might aid in your diagnosis is considered cytology. You can consider PCR or culture and sensitivity, but those are usually we do with infected ulcers, or if there's a feline conjunctivitis case. And it's always almost important to do a recheck to see whether we have resolved the problem. Now, moving on to follicular conjunctivitis. This is a non-specific reaction to chronic conjunctivitis, and it can be easily recognized by the appearance of nodule-like structures. Even here, you can see some few nodules in the eye. So they're mostly present on the seen in the conjunctival fornix or the posterior surface of the third eyelid. You can take a bit of a soap and look under the light microscope, and you would predominantly see lymphocytes and plasmacytes. So they quite respond very well to steroid eye drops. Pred 40 is the treatment of choice, but make sure you don't have any ulcers happening, because if there's any ulcers, it can result in an infected melting ulcer if you use steroid drops on an ulcer. So if we have a recurrent conjunctivitis case, you might want to try and dig out and see whether there's an underlying cause. For example, there could be dry eyes, foreign bodies or tumors, allergies. Again, you ask the question whether it's seasonal and if it's responding to Pred or Maxidex. And sometimes there might be ectopic cilia or extra eyelashes which are irritating the eye, which sort of causes recurrent conjunctivitis. Whether there's any eyelid and abnormalities, is there a tumor on the eyelid which keeps rubbing on the cornea, or is there any ectropion or entropion problems? Now, feline conjunctivitis is quite common with herpes and chlamydia cases. Now, usually with herpes viral infections, you can see other signs like flu signs, sneezing, anorexia, running a bit of temperature. And with also you would see feline conjunctivitis predominantly with chlamydia. So it's a good idea always to send a swab for PCR to determine which infectious agent you're dealing with, and depending your treatment line might vary. Now with herpes virus, what we currently use, we predominantly use famiciclovir 90 mg per kit twice a day for about 10 to 14 days or until better. Acyclovir topical ointment is also available, and if it's a good cat who would let you do an eye ointment 5 times a day, then you could try the acyclovir. So it might take up to 10 days or even longer. Now, if you're suspecting chlamydia, so ideally with chlamydia, you need to do doxycycline. Now, chlamydia, you most commonly see a very edematous conjunctiva, like you saw in the previous slide, and sometimes you can't even see the eyeball. Now, the other eye might be quite looking normal, but this eye might be like this. So in those cases, you don't really see any flu signs in them. It's mainly the eye conjunctivitis that you see in them. In these cases, you can start doxycycline. So you go with 5 mg per kg twice a day for 21 days. You can also with cats, it's a good idea to always use a artificial tear, so 1 drop 2 to 3 times a day. This protects the cornea against secondary dry eyes. Now, if the redness persists, you can couple it with an NSAID like Voltaren, but the problem is most cats react to Voltaren, so you might want to try Ocular or Ketorolac, which are more cat friendly. Now, another common complaint is ocular discharge. So it could be either watery or mucky. Now, we always, again, do a Schirmer tear test, and if it's more than 20 millimeter wetting, this suggests an irritation that might be causing the epiphora. Now, if you have a normal tear test around 15 millimeter, and still you've got an epiphora, so this suggests there might be a blocked tear duct or decreased nasolacrimal passage. Okay, so a good way to have a look is if you do the fluorescein dye test. So this dye, it should drain from the nasolacrimal gland to the same side nostril. But it might take a bit of time. So what you can do is you can do the dye and then do a full exam, let the dog sniff around the consult room, or maybe give a treat, because more the patient looks down, it's gonna drain to the nostril quicker. So, and then re-examine again. Now, if you don't see any dye on that nostril, you might want to give another 5 minutes and recheck again. But if you still don't have anything, you can open the mouth and have a look. Sometimes you might see the dye in the back of the throat, in the nasopharynx. But if it's still not there, so you might have a case where you need to flush the tear duct. And the other benefit of doing the fluorescein test is you can easily see corneal ulcers, because they if there's an ulcer or defect in the cornea, they do take up the dye. Now, a healthy cornea would not take up the fluorescein dye because it's lipophilic and it repels the water. Okay, now if you've got a mucky ocular discharge, so you need to think whether it's a foreign body which is causing continuous irritation, or is there an infection, nasolacrimal duct infection. Sometimes with chronic conjunctivitis with secondary bacterial infection can also cause a mucky ocular discharge, but the most common one is if it keeps reoccurring, it's most likely it's dry eyes. Now, dry eyes can be easily overlooked, so that's why we usually always say with any eye cases, always to do a Schirmer tear test, because if you catch it early and treat it early, start the treatments early, they respond very well to the medication. But if you delay the treatment or catch it after it has progressed quite a bit, it's quite a bit hard to reverse it back. Okay, now causes for canine conjunctivitis. So they're mostly immune mediated, but the majority of cases are idiopathic but immune mediated destruction of the lacrimal glandular tissue. They're most likely to respond to topical cyclosporin. Now, sometimes it could be secondary in some dogs like toy breeds or Yorkshire Terriers, it's due to developmental problems, and as in a hypoplasia in these doggies, you would see an absolute sicca. There's no tear production whatsoever, and it could be bilateral or unilateral, and would unlikely respond to medication because there's no acina to produce any tears. So it's not going to respond to meds. So the only treatment option left is parotid duct transposition surgery. Otherwise, you'd be looking into providing artificial tears quite a bit often. Right, and sometimes you might see dry eyes secondary to infections. And once the infection is under control, usually in these cases, the tear production resumes. Sometimes you might see cases happening secondary to trauma or inflammation of the lacrimal gland, or blood supply problems, innervation problems, facial nerve damage, and things like that. So in these cases also, if they resume back to normal, if they resume back to normal, the tear production might be resumed. Another interesting condition is neurogenic KCS. It's again commonly associated with injury to the cranial nerve 7, which is the facial nerve. Sometimes we see this following a middle ear disease. Now, also there are other causes that can cause KCS. Mainly, some drugs can cause KCS. Sulfonides is one of those culprits, sometimes with topical or systemic atropine, opioids that can also cause a transient dry eye condition. Sometimes if you have an cancer doggy who has been treated for cancer with radiation therapy, then you might get secondary dry eyes treated. Sometimes you might see dry eyes in association with metabolic diseases, for example with diabetes, because secondary due to reduced corneal sensitivity, you might end up having a reduced reflex tearing. And sometimes you might also see with hyperthyroid or hyperadrenocortisol due to the hormonal influence in tear production. Another most common cause is iatrogenic. So that's, now if you get a cherry eye condition in a dog, some vets tend to remove the tear gland. So if you remove the tear gland, there won't be any tear production in that eye, and it would eventually lead to dry eyes and eventually scarring and ulceration of the cornea. So never remove the tear gland if you have a cherry eye. So it's always good to perform the cherry eye surgery, which is quite easy once you get learn it. Right, so so most commonly we see cases secondary to autoimmune conditions. Now this can be over the course of the conjunctivitis. Now there's quite a bit of predisposition in this. So the most commonly seen breeds are West Highland White Terrier, Cavalier King Charles Spaniels, Shih Tzus, miniature Schnauzers, Bulldogs, Bull Terriers, Pugs, Cocker Spaniels, and Poodles. And so if you can catch it early, as I said earlier, you get best results if the initial schermatitis reading is over 5, and if you have caught within 6 months of the disease, then you get the best results. So that's why we always say to do a schermatitis with all cases of ocular disease. So with management, this could be either medical or surgical, but we always prefer to have it managed medically. That is with the drops and ointments, because surgery in itself carries out a bit of complications and its own problems. Now, the first line treatment we use is Optiumine. We use Optiumine twice a day. Now, Optiumine is a cyclosporine ointment, 0.2% cyclosporine. Now, if the spermatitis is less than 6 millimeter, then you would consider doing it 3 times a day, and you might want to reassess in 4 weeks' time. Now, if the cyclosporine 0.2% is not responding well, then you can trial an increased concentration up to 1% or 2%. Now, 80% of early KCS cases when treated with cyclosporine will return to normal, provided that you have caught them early. Now, most dogs will require prolonged treatment and sometimes might need lifelong treatment. Now, another thing with any eye medications, is always good to put some artificial tears and clean up your eye before you do the drops, because otherwise mucus can stop the active drugs from getting to the lacrimal gland. Now, if your patient is not responding with the Optiumine, then you can go to the second line, which is tacrolimus. This is a compounded medication. You can use 0.02% to start with. This is an off-label use eye ointment, and always let your clients know that it's off-label and to wear gloves, because there is a risk of carcinogenicity, and especially do not let any kids touch it. So you need to make sure that the owners are keeping them on a higher shelf where the kids can't get into. Right. Now, so cortisone ointment can be coupled with to improve the corneal health, because it will help reduce the associated vascular keratitis, but always make sure you don't have any ulcers. Now, if your medical treatment is going to fail, then you can look into surgery option. It's parotid duct transposition surgery, and it's mainly redirecting the parotid saliva to the ventral conjunctival fornix. So 80% of the dogs would be comfortable after this surgery. However, you must always remember that saliva differs from the tears. Now, the saliva has got quite a bit of increased amounts of minerals, high pH and digestive enzymes, and it can cause problems due to this. So it might lead to corneal mineralization, blepharitis, and then you might be wanting to do ongoing treatments and medical management still. So it's a bit of a problem. And also with the surgery, in about 5% of the cases, the eye might be still still would be dry. So you might be still end up in a dry eye case still, and the surgery would be a failure. And in another 10% of cases, the eye might be too wet. So, and then you might need to do revision surgery. So you might want to talk about all of these before you go ahead with the surgical option. And here in Australia, we don't perform the parotid duct transposition in a GP clinic. We always would refer them to an ophthalmologist. Now, if we have a refractory KCS, then we always refer them to an ophthalmologist, which is a luxury we have. Now, you can also consider combining Optiumine and tacrolimus in refractory cases. And recent work suggests that there can be the refractory cases can be improved by using a combination of those two drugs. Now, if you have a case where you are not going ahead with the surgery and there's no whatsoever improvement with the medical management, then you need to have a think what we're going to choose. So then the only last resort that's left is managing the eye with artificial tears as much as you can. Now, artificial tears, you can use drops or ointments. Now, if you're using a drop, you'd need to do every 1 to 2 hours, which might be a bit of a hassle if you've got a working owner who's not at home. So in that case, you can couple with the ointment. But the best results, the drops are the best for the corneal health. It provides much more good lubrication compared to the ointment. But ointment, it comes in handy in the night. You can do the ointment just before going to sleep, so it keeps the eye nice and lubricated. And also if you're going for work, you can put it and go, so it sort of helps with the to stand a bit longer till you can do the drops again. Right. So another interesting condition is, as I said, neurogenic cases. Now, you most commonly see this secondary to an injury to the cranial nerve 7, which is the facial nerve. Sometimes you might see following middle ear infection. And sometimes you might see this happening after you've done post-sulfur drugs or atropine treatment. Now, clinical signs, again, you would see dry eyes and sometimes a reduction or failure in the blink response. The other most striking clinical sign you would see is the concurrent nostril is quite dry. So in these cases, if you measure the tear test, it's going to be a 0 tear test, absolute sicca. So the treatment line is you use pilocarpine, the ophthalmic, you can use the ophthalmic pilocarpine drops, but you give it orally, because the topical, when you use it topical on the eye, it's quite very irritating and even can lead to uveitis, and your patient is not going to be compliant anyway. So oral dosing is done, and it needs individualization. Now, dose needs to be titrated to just below you getting the systemic toxic signs. Now, the most common toxic signs that you see is vomiting, anorexia, but also can have diarrhea and bradycardia. Okay, so let's look at how to pilocarpine dosing. Now, you can use 1% pilocarpine for dogs who are less than 4 kilos and 2% for 4 to 20 kilo dogs. And you might want to use 4% pilocarpine drop for the dogs over 20 kilos. Now, initial dosing is you do 1 drop twice a day orally for about 3 days. Now, once you do these 3 days, if no problems, then you increase the dose by 1 drop every 3 days until you see the earlier signs of toxicity. Now, usually earlier signs would be vomiting and anorexia and no diarrhea. So you want to have a good talk with your client and educate them of what you're looking for. So you don't really need to wait till the toxicities happen. If they're responding prior to that dose. So you can always check the Schirmer-Tear test every 2 days, and if your Schirmer-Tear test is improved up to the level that you would like, then you can stop at that dose. But otherwise, you can keep increasing the dose till you see the earliest toxic signs. Now, the drug, if you see the toxic signs like vomiting or anorexia, you need to stop the drug for 24 hours or until the GI signs have resolved, and then you can restart with the highest dose, which did not produce any systemic toxicity. Now, there's another way that you can do, you can do another regime, like you can combine this pilocarpine with phenylephrine. You can use 2.5% phenylephrine, and this actually helps to constrict the smooth muscle fibers in the lacrimal gland to express the tears. So what you do with combining the pilocarpine is you are using the pilocarpine to stimulate the tear production, and then the phenylephrine to stimulate the tears to be secreted. So together you get a better effective production of tears. Right. Let's look into the corneal ulcers, which we usually always see. Now, again, we always do a Schirmer-Tear test because you never know, it could be secondary to dry eyes. You do a fluorescein test, see whether there's any dye uptake. That's how you diagnose an ulcer. And the biggest concern when we have a corneal ulcer is there any infection going on? And if you are doing any anti-inflammatories, you need to stop if there's an infection. You need to consider whether it's secondary due to other causes like eyelid abnormalities, dry eye conditions, or whether it's mechanical. Again, treatment, if you have an ulcer, you'd want to start topical antibiotics. So the first line is you go with a broad spectrum antibiotic like chloramphenicol, or you can have a combined one like opticine, or a 3 antibiotic ointment like trizine. Now you essentially reserve the potent antibiotics like fluoroquinolones, for example, Ocuflox or ciprofloxacin, or and gentamicin for the infected corneas. Now we always start doxycycline orally, 5 mg per kg twice a day, because it comes with a good concentration in the eye and provides a good coverage for the antibacterial for an infection, and also it has a corneal healing property. Now, corneal ulcers are always very painful. When it goes to the stroma, of course, it's not painful, but if it's a superficial corneal ulcer, it's quite very painful, and you'd almost always see the dog is squinting the eye a bit. So always make sure to start on an NSAID. You can either use Metacam or Oncio. Atropine, you might want to use atropine if the pupils are constricted, but make sure you're not dealing with a glaucoma patient, because it can increase the intraocular pressure, and if it's a dry eye patient, it can get worse with atropine. So you might want to play with the dose, or you might want to just leave it away. Now, another special thing that we use with ulcers is we use Claraplic, which is a carboxymethyl glucose sulfate polymer, which provides a good base for ulcer healing. It promotes corneal ulcers. You can put 1 to 2 drops per eye every 2 days. Now, if we have a corneal ulcer, now usually a normal corneal ulcer would heal within 5 to 6 days, but if it's taking more than that and taking more than 2 weeks, it's considered as a slow healing ulcer. Now, a slow healing superficial corneal ulcer is called an indolent ulcer. Now, if you have an indolent ulcer, you might want to consider debriding. So you can actually use a sterile cotton tip to debride all the loose epithelium. Now, this can be also done in the consult room. If you got a very good patient, you can just put a drop of Alkane, a local anesthetic, and you can sort of try and debride while the dog is awake. So some dogs let you do that, but if it's a fractious dog or a jumping up and down dog, then you might want to consider GA or sedation. And then in that case, you might want to do a grid keratotomy. You can use a 25 gauge needle to do a grid keratotomy. And my cursor is gone anyway. In that linear incision, so you with the 25 gauge needle, you might want to do a linear incision to the superficial corneal stroma dorsoventrally, and then the grids by making linear incisions at 90 degrees. So you have a little grid keratotomy. Now, you can actually put a third eyelid flap afterwards, or a tarsorrhaphy. Now, we prefer to do a tarsorrhaphy over a third eyelid flap. The reason is with the third eyelid flap, you don't know what's happening inside there. You can't have a sneak peek, or you can't put any medication into that. So if you do a tarsorrhaphy, you can do it in a way that you can loosen the knot and look into the eye and put medication as well. So in that way, you can still monitor the eye. Otherwise, you can just leave the eye as it is. Some vets prefer to do an eye patch like that. So that's up to you, but always put an e-collar so that the doggy is not going to rub on the eye and make things worse. And it's very important that you never perform a grid keratotomy in cats, because with cats almost always ulcers are secondary to infection, and you will end up in having a sequestration. Now, also, you don't do a keratotomy in deep ulcers or infected ulcers, because you can end up rupturing the eye. Even in edematous corneas, we do not do that. And with an ulcer that you debrided or done a keratotomy, it takes up to 7 to 10 days to heal properly. So leave at least 2 weeks before you repeat a grid keratotomy. Usually you wouldn't need to, but if you want to, you have to at least leave 2 weeks and then reassess and decide. Right. Now, when the ulcerative process erodes through the corneal epithelium and go through the stroma and exposes the Descemet's membrane, then you have a Descemetocele. Now, if you have a Descemetocele, it's a medical emergency, and what we usually do here is we straight away refer to an ophthalmologist, which is great, and they take care of it. Now, the reason why we do that is it's easily ruptured, because in that point where it's going to be a Descemetocele, that area is very, very fragile, and it can rupture even with the animal just going once. So you can see, so it might have a appearance of a deep ulcer surrounded by edematous cornea, which might be fluorescein positive. I'm not sure where my cursor is gone. Oh, here we are. Okay, so here in this eye, you can see there's a bit of diaptech, so there is an active ulcer. Again, the cursor is gone. Okay, so there is an active ulcer here, but here you can see the Descemetocele, and inside it looks like a well-like structure where there's no diaptech, and the surrounding is like a bit of edematous and slightly staining. So that's the Descemetocele, and if you see that, as I said, this area is very, very fragile and can rupture with the slightest irritation. Okay, so I understand sometimes you might not have the opportunity to refer to an ophthalmologist. In those cases, the treatment that you can do is you'll have to start with the topical broad spectrum antibiotic and make sure you do NSAIDs. Now, the problem with Descemetoceles are they're not painful, because once you go away from the cornea, now cornea is the one, if you have a superficial ulcer, it's very painful, but as soon as you rupture and goes through the stroma, it becomes non-painful. And the dog might be jumping up and down, which in itself can cause a rupture. So you need to make sure that the dog is rested, put an e-collar always to protect the eye from any pawing. And you might want to decide on mediatrics. If the eye's got constricted pupils, you might want to do them, but then you might want to consider whether there's increased ocular, intraocular pressure and things like that. So ideally, you need to do a conjunctival graft. So the conjunctival graft, it requires special lenses and instruments, but it can be done. Right, so now we move on to infected ulcers, and you call them a melting cornea. So it's again considered as a medical emergency, and if you see any of those, we again straight away refer them to the ophthalmic specialist, but because they are at high risk of rupturing and losing the eye again. So these are characterized by rapid progression of softening and destruction of the corneal stroma, and mainly by proteases and collagenase enzymes, now produced by the bacteria or the host's immune inflammatory cells. So you see a bit of a gray gelatinous corneal appearance, and the corneal surface becomes a bit irregular and gives that melting ulcer appearance. So usually we see infectious agents such as Pseudomonas or Streptococcus. So if you got an infected ulcer, always do a cytology and send for culture sensitivity. And when you do a cytology, you might, if you see rods, it's most likely it's Pseudomonas. So then you can start something like gentamicin. But if you see cocci, it would be, you can even respond to chloramphenicol. So with cats, it's almost always a feline herpes virus or mycoplasma. So you might want to do a PCR in cats cases. Always, I would do either cytology, culture sensitivity, and PCR. Now, looking into treatment. So before we start any treatments, it's, as I said, you need to do cytology and sensitivity test, because in case it's not responding, then you have something to bounce back to. Now, antibiotic drops are used every 5 minutes for the first hour in these cases to get a good control of the infection. Now, after that hour, then you do hourly, and then depending on the improvement, you might do every 2 to 4 hours. So a common, the most common drugs used is gentamicin. You might use it hourly, or you can use a fluoroquinolone like Ociflox or Cipro 2 hourly combined with fusidic acid or chloramphenicol. Now we usually always start on doxycycline 5 mg/kg twice a day. Because doxy achieves good levels in the eye, providing additional antibiotic coverage, and also seems to have an anti-collagenase activity and have a positive effect on the corneal healing. And we also might consider doing a tear replacement, like with hyaluronate tear replacement every 4 hours, especially if you are dealing with a dry eye patient. And also you can decide whether you want to use atropine or not. Again, if you got a myotic people or constricted people, you might want to use this, but again, you need to make sure you're not dealing with a glaucoma patient. Oral NSAIDs are always used. It's important to control pain and excessive host response in these ones. And you might want to couple with gabapentin sometimes to keep the patient comfortable, and gabapentin also has a little bit of a sedative effect. Serum drops are used quite often. These decrease the collagen breakdown, so you can separate the serum and refrigerate it up to 5 to 7 days with no problems. And sometimes we tend to use a supplement called durolactin. Now, this is a dried milk protein, and which is known to inhibit migration and infiltration of neutrophils. Cats always we medicate either for feline herpes or chlamydia. And that's why we always send PCR samples, so we can, if the treatment is not working, then you know what we are dealing with. Also, it's really important that you have the conversation with the owners and advice to on the treatment, and that we need to treat on the clock, because this is, if it's not treated aggressively, you might lose the eye. Now, the patients should become more comfortable in about 48 hours. After 72 hours, usually we see a marked improvement and the frequency of topical medications can be reduced. Now, if you don't see any improvement whatsoever, then the next step is surgical. You might want to consider surgery. So the most common surgical method is you do conjunctival grafting to stabilize the melting cornea. So it provides anticholinergic effect plus structural support and direct fibrovascular healing. But as I said, we don't perform this in a GP practice in Australia. One, we don't have the necessary instruments or the expertise, so we always refer to an ophthalmologist for these advanced cases. Okay, now moving on to uveitis. Now, uveitis is a general term to describe inflammation of the intraocular vascular uveal tract, that is iris, ciliary body, and the choroid. Now, you might see a breakdown of the blood-eye barrier and inflammatory cells getting to the eye and causing uveitis. Now, once you get uveitis, they can keep recurring every now and again. So prolonged treatment is really, really important. Sometimes you might see WBC settling down, and even in this eye, you can see, if you look carefully, there's a bit of hyperpyon here. Right. So the most common clinical signs. Okay, so sorry about that. Oh. Just give me a second. Okay, sorry about that. So again, coming back to our clinical signs, you might see blepharospasm, epiphora, bloodshot eyes, hyperemia, due to episcleral and conjunctival vascular injection. So one of the most prominent ones are meiosis. And you can actually use this as a guide of how well your uveitis is being controlled. Now, if it's unilateral, you might see anisocoria or unequal pupil sizes. Now, intraocular pressure tends to decrease with the uveitis. Again, this is used as an indication to guide you of how well your uveitis is controlled. Photophobia is quite common with uveitis. The animal goes, squints or turns away from the light. Sometimes you can see decreased vision or blindness, and once you control this, it might be reversible. Corneal edema, and commonly you would see an aqueous flare. Now, aqueous flare is when you shine a bright light onto the eye, you just see like a headlights in the fog-like appearance in there. So those are the most common clinical signs. So they're very painful eyes when you have uveitis. So you need to make sure that you control the pain. And also, so with constricted pupils, now you might be wanting to look into the back of the fundus, and you might try with the normal usual thing we do is we use 1% tropicamide to dilate the pupils to look into the back of the fundus. Now, when you are doing this test, you might see a very, very sluggish response for the tropicamide in uveitis patients. So that's also another indication of uveitis, that the patient's having uveitis. Now, if you get a case of bilateral uveitis, always you might want to rule out any systemic diseases. So you might want to run some blood tests, blood pressure tests. So just to rule out it's not secondary due to hypertension or renal problems and or other problems. Now, if not controlled, if uveitis is not controlled properly, it can progress to glaucoma and even retinal detachment and complete blindness. So it's really important that you control uveitis. Okay, let's look at the treatments. Most commonly, we use the degree of the pupil dilatation as a guide of how well the uveitis is being controlled. Now, treatment for clinical signs include ocular medication with systemic anti-inflammatories and topical atropine. So the medical medication may alter with pre-existing conditions. Like if you've got a corneal ulcer, you might be omitting the PRED 40 because you can't use PRED with corneal ulcers. But the first line or treatment is PRED 40 if you don't have any ulcers, because it's the most potent and best penetration and gives you really good results. You can also use dexamethasone. For mild uveitis, you can do twice a day to 3 times a day dosing. But if it's severe, then you might want to consider every 2 to 4 hour dosing. Now, if you've got corneal ulcers, then you'll have to stay away from steroids. And then you might want to do NSAIDs, topical drops every 2 to 4 times daily. Now, atropine is also indicated in uveitis because you usually get myotic pupils. However, if you got a glaucoma patient, you would not be using atropine. And bear in mind that dry eye cases can also go downhill with atropine. Now, it's you need to essentially use oral anti-inflammatories to get uveitis under control. But if you're using cortisones, now the cortisones are the most effective. You can use prednisolone 2 mg/kg daily in divided doses until the uveitis is under control, but make sure first there's no systemic infections happening or there's no corneal ulcers. Now, in cases that you can't do cortisone, then you can go to doing NSAIDs. And also NSAIDs can be used in longer term treatment and in less severe cases. Now, subconjunctival depot cortisone injections also are indicated in refractory cases, but not usually done in a GP practice. Now, as I said, we use the intraocular pressure as a guide to your uveitis treatment. Now, the intraocular pressure decreases in uveitis, as I've said before, and so you have to make sure before you stop the treatments that the IOP has come into the normal range. Now, if the eye is clinically looking normal and comfortable, but if the IOP or intraocular pressure is still low, then you need to continue treatment regardless. Now, once the IOP comes to normal, which is around 10 to 25, then you would consider uveitis has been controlled. So with uveitis, always use systemic therapy, otherwise you can't get it under control. Prolonged treatment is indicated and would be needed to have a good control. So sometimes you would be going for 2 to 4 weeks post-resolution of the condition, otherwise it might reoccur again. And even if you go for that amount of time, there is still a chance of recurrences. So you have to have this conversation with the client and educate them that it's possible that they can be reoccurring, and it needs prolonged treatment. Otherwise, the clients can get frustrated and then stop the therapy in the middle, doesn't come for revisits, which are really, really important in the management, in proper management of uveitis and success. Okay. So let's move on to glaucoma. Now, we'll have a look at acute glaucoma. Now, this is actually the result of an impaired aqueous outflow, and damage can be irreversible, leading to blindness if you don't control it, and within 24 to 48 hours, you might have a blind eye. So it's you usually would be seeing a red eye. So here you can see in this eye, you are looking at a deep perilimbal hyperemia, so you get a red eye, plus a blue eye due to corneal edema. Now, these conditions, these acute glaucoma, even chronic glaucoma, are severe. It's quite very painful. In humans, they get headaches, but the dogs can't say I've got a headache. They show it by being lethargic. So you would see quite a bit of a lethargic animal in with glaucoma. Now, you might have a dilated non-responsive pupil. Sometimes it might be a sluggish PLR. Always measure the ocular pressure with a tonometer or toner pen, and the normal IOP sits between 10 to 25, so a glaucoma is considered as over 30 mercury millimeter reading. Right, so if uncontrolled, it can lead to blindness and losing the eye because it might damage the retina. With acute glaucoma, usually the eye or the globe size is normal. Now, if you look into chronic glaucoma, you would see the acute signs, plus you would see a bulging or an ophthalmic eye, so an enlarged eye. So usually when the eye is enlarged, the eye is blind, but not always. So don't lose hope. You would still start your treatment, try to get the eye pressure down as quickly as you can. So initial stages of ophthalmic, as I said, the optic nerve may not be damaged. So there is still hope that we can get the vision to return. So what we usually do is, in glaucoma, with acute glaucoma, even we refer to an ophthalmologist, where they can do the treatments and monitor them very closely, because you need to be aggressive in the treatment, otherwise you lose the eye. But if you are going to manage it in a GP practice, you ideally need a toner pen and all the medications that you need to. But yeah, so always check for vision before and after getting the eye pressure down. So here you can, with chronic glaucoma, another sign is you can sort of see Harb's striae. So these are actually the linear breakage in the Descemetoceles membrane due to increased pressure. Sometimes you might see lens subluxation. Now, glaucoma can happen secondary to lens subluxation and vice versa. And this subluxated lens can block the drainage angle. Now, if you got a blind eye, the only thing you can do is either remove the eye, or you can put an intraocular silicone prosthesis. In the first doggy, you can see that it's an enucleation, but the second doggy, he's got an intraocular prosthesis. Now you call it as a glass eye. We have one patient like that. So that eye can't focus or anything, but it sits there, so it gives a good cosmetic effect. Now, so the important thing is, if you got glaucoma in one eye, even though the intraocular pressure is normal on the other eye, always use preventative treatment. So the most common preventative drug used is Azaga. It's a combination of benzolamide and timolol. Now, when we treat, it's good to know whether it's a primary glaucoma or a secondary glaucoma. With primary glaucoma, it's mostly secondary due to a blocked outflow of fluid from the eye due to an abnormal drainage angle. Now, so if you have a drainage angle problem in one eye, most likely, and glaucoma in that eye, most likely the other eye has got a drainage angle problem, and glaucoma might follow after a few months. Usually after 6 months, you might see glaucoma in the other eye too. So in breeds that are common to have primary glaucoma, such as Basset Hounds, Cocker Spaniels, English Springer Spaniel, Australian Cattle Dog, Fox Terriers, Poodles, Maltese Terriers, Golden Retrievers, and Great Danes. If you have a problem with primary glaucoma in one eye, you always check the other eye. Now you need a special lens called gonioscopy, and you can check the drainage angle with that to see whether that eye is also predisposed. So, and most likely they are both eyes are affected, but one eye gets glaucoma first and the other eye follows after a few months' time. So always start preventative treatment to the other eye as well. Now, secondary glaucoma can happen secondary to anterior uveitis or lens luxation, and as I said, it can block the drainage angle with the lens, with the luxated lens. And sometimes there could be tumors which obstruct the angle. Cataracts can also obstruct the drainage angle because cataract lenses swell up, uptaking the fluid. So yeah, you might want to see whether it's primary or secondary glaucoma. Now with cats, it's most commonly secondary to some secondary problem. Most commonly uveitis or intraocular neoplasia is common in cats, and sometimes systemic diseases like renal problems, or the cat might be having hypertension and secondary glaucoma due to that. So it's always good to check the bloods and do a blood pressure check with the cats. And we usually try intensive treatment and to get the pressure down, because if the pressure you can't get down, if it can't be controlled with the medication, then you need to consider surgery. So the most common treatments for acute glaucoma, your treatment goal is to save and restore the vision if the vision is not there. For medications to work, there should be some drainage function present. And so it's really important that you're able to examine the drainage angle. That's one reason again that we refer them directly to the specialist, so they can have a good look with the gonioscopy and do a gonioscopy examination to see whether there's drainage still happening. So the most common drugs used are carbonic anhydrase inhibitors. These reduce the aqueous production by about 40%. So most commonly we use Corsop 3 times a day. Also, you can use prostanoids, but not if you already have uveitis or lens luxation, so they can aggravate this. So if you don't have any of these, then yes, you can consider doing prostanoids. They are quite very effective. Salatane and Travoprost are the most common prostanoid drops that we use. These increase the outflow, UV scleral outflow, and helps to get the aqueous going away. Also in emergency cases, you can use hyposmotic agents like mannitol. This is to get a quick effect, and you can give 1 to 2 grams per kg over 30 minutes. Now you can use beta blockers, but these are usually commonly used in preventative treatment rather than treatment. Now, if there's no drainage function present, you need to consider surgery to create an alternative outflow path. You might want to put indwelling anterior chamber tubes or implants, and sometimes you use cryosurgery or direct laser to destroy some of the fluid producing cells in the eye. Now, again, these are not done in a GP practice. These are done with the ophthalmology specialist practices and who have the correct proper equipment and the expertise to perform these. Okay, another most commonly seen eye problem is cataract in a general practice. Now, a cataract is an opacity of the lens. It forms with the disruption of the lens fibers. Now, as the cataract forms, the lens proteins inside the eye changes, and these changes sometimes allows the lens protein to leak into the inside of the eye, and we end up in having lens-induced uveitis. Now, that's a big problem with cataracts. So, because it's possible that we can get lens-induced uveitis, we always use a topical anti-inflammatory with all the cataracts. What we usually use is Voltaren once a day dosing. We do it at the first, you can start it at the first sign of cataracts, even if the intraocular pressure is normal and the eye is comfortable, still start it. So for cataracts to happen, there might not be a specific cause, but possible causes could be diabetics. So in diabetic dogs, you would see cataract happening pretty quickly, and they advance very quickly over weeks to months. And sometimes with hyperhidrocorticism also you see cataracts happening because of the glucose levels go up and down. And with progressive retinal atrophy, also you would see cataracts happening. So they could be inherited, and especially purebreds like poodles, cocker spaniels, Australian cattle dogs, Maltese, Boston terriers, golden retrievers, and silky terriers. This can be a inherited problem. And in those cases, there's no point in doing cataract surgery because you got a problematic retina and your vision cannot be restored. Now, looking into diabetic cataracts, they're very prone to lens-induced uveitis, secondary due to lens protein leakage. Now, they develop very quickly. Within few days, they can develop to have fully mature cataract, and they start initially as vacuoles, small bubbles on the edge of the lens, and that's why we always say it's good to build up an eye examination as part of a routine health check or when they come for a vaccine. So then you can look into the eyes, so then you get familiar with eye condition, and then you can catch what's abnormal. And you can catch these little changes at early stages before they progress down the track. Now, with diabetic cataracts, we often see huge lenses, very swollen, and even in this eye, you can see a slight Y-like things. You see the lens switches because the water is gone into the lens, and it's very swollen. Yes, so treatment, as I said, we start with an NSAID to keep uveitis at bay, and we can start on Ocular. This is an oral antioxidant formulation which is known to delay canine diabetic cataract. So there's a few studies done on that if you want to look up. Now, so sometimes there could be an owner who is happy to do cataract surgery. So if you are considering cataract surgery, now we don't again do this in our GP practice. We refer them to an ophthalmologist if there's someone who is interested in cataract surgery, because you need to assess your retinal health. Sometimes you would need to do an electroretinograph and see how well the retina is responding. And if the retina is not healthy, then no point in doing a cataract surgery, because you cannot restore the vision. And if you're considering a cataract surgery, you need to ideally refer in the early stages for fundus evaluation and before you get any lens-induced uveitis, because these will reduce the outcome of the surgery. And plus, you might want to discuss with the owners that, again, with these surgeries, sometimes it might still end up being a blind eye. So there's a bit of failure rate, quite a bit of higher failure rates in cataract surgery still. So you might still end up in having a blind eye after taking the trouble to go through a cataract surgery. So you need to prepare the owners for that as well. All righty, so moving on to the last topic of our talk. So pannus or chronic superficial keratitis. So this is again an inflammatory, potentially blinding disease of the cornea. So it's characterized histopathologically by a lymphoplasmacytic infiltrate in the anterior stroma. So this condition is idiopathic, but has an immune-mediated etiology. So it responds very well for medication if you do it properly. Now, predisposing factors are high ultraviolet light, high altitude, smoke. So the most common breeds that you see are the shepherds, German shepherds, Belgian shepherds. You might see in greyhounds and border collies as well. So in the few years I've practiced, I've only seen mainly in German shepherds, Belgian shepherds and greyhounds. I've not really seen in any other breeds, but it's also possible to have any other breeds with this condition as well. Okay. Now, looking into the clinical signs, you would see pigmentation, brown accumulation into the cornea. And as you can see here, it usually starts from the lateral and then comes to the medial aspect of the eye. So vascular changes with blood vessels can grow into the cornea from lateral towards the medial aspect. And it usually appears pink and fleshy. Now, both eyes can be affected, but one eye may appear worse than the other. Corneal cloudiness with lipid and fibrosis sometimes is also seen, and sometimes you might see thickening of the third eyelid with loss of pigmentation on the third eyelid margin. Now, you don't usually see much pain in the early stages, and the dog is quite comfortable with the eye. It's just you see a fleshy thing growing in towards the eye. But in the latter stages, there might be pain and ocular discharge. So the condition can be well controlled with medication and may be able to reverse some changes, but it won't cure. So you might usually need to be medicating lifelong. So if not treated, the cornea can scar permanently and get pigmented and dark in color, and potentially vision loss can be due to inability to see through those dark pigments covering the cornea. Now, sometimes, as in the first slide, you can see the first eye, it's only starting. Now, the second eye, it's gone to the middle of the cornea, and the third eye, if you don't treat, this is what's going to happen. It's going to cover the whole eye and end up in having a blind eye. So you can use topicals, cortisone, pred, or Maxidex, provided you don't have any ulcers. You can combine them with cyclosporin or tacrolimus. Lifelong medication is most likely, and regular checkups are needed for continuous monitoring because relapses are quite common. Now, initially, you can start 7 to 10 days cyclosporin twice a day, coupled with a topical corticosteroid, and then slowly reduce the corticosteroids. So, for example, you can do Maxidex 4 times a day for the first week, and then 3 times a day for the second week, and then twice a day the third week, and then 4th week you do once a day, and then you stop. And this is coupled with the cyclosporin, which you do twice a day for 8 weeks. And then if you have a good control, then you might want to reduce the cyclosporin. You can do once a day dosing or every second day. But as I said, relapses are common, so always keep in check. Now, these can worsen during summertime, so we discourage high UV exposure when it's summer. So during high UV index days, we tell the owners to restrict access to outdoors, or you can get doggy sunglasses. Now, in severe cases, of course, if no one's treated and then the whole eye is covering, you can consider surgical removal of the scar tissue and scar tissue, but again, that's not done in GP practice. It's often always referred to an ophthalmologist. All righty, so at the end of the talk, so my references, the mostly I got info to my talk from an ophthalmology CPD course that I attended in the at the University of Sydney, and also Basava Manual of Canine and Feline Ophthalmology. This is a really handy book to have. It gives you got good information about eye conditions, and also Merck's website is a good resource, and CPD materials from a specialist ophthalmologist here in Melbourne. So thank you very much for joining me with the talk, and I would like to hand over to Dr. Gayani to continue. Thank you.
Thank you very much, Dr. Gayani, for your informative talk. Actually, it contains a lot of valuable information and tips that can be applicable to day-to-day practice. So now the floor is open for questions from the audience. You all can type your questions in the chat box so that we can take up your questions one by one. Or else if you just indicate by hand raise, we will be able to accommodate you as well. So I'll go to the first one. This is from Dr. Samanthi Ratnasiri. Is chloramphenicol eye drop available in your country?
Yes, it is. You get it as Chlorop here. So Chlorop is the chloramphenicol antibiotic here.
And then we have another question from Dr. Hasinta. How do we rule out chronic cases? Especially most of chronic cases, we cannot differentiate practically. So do you have any suggestions for this to differentiate the chronic cases?
So it's mainly the history. You need to ask the owner, when did this happen? Hasn't happened before? How long has it been there? So you would get an idea. But regardless, if you have a chronic or acute case, your treatment line is more or less the same. The outcome can differ, yes, in case, yes. If you've got a chronic case, you might not be responding to cyclosporin. In that case, you might want to look into either doing tacrolimus or a combination of drugs, but it's mainly depending on the history. That's why we usually say when they come into vaccination or anything like that, always do a proper exam, including an eye examination, so you can catch things earlier.
Okay, Dr. Gayani. So until we get more questions from the audience, I have a small question. I myself has seen the benefit of using the serum eye drops in order to treat the melting cornea conditions. So probably even our audience, some may have used it, some may have not used it. So can you give us a little bit more information about the serum eye drops that you have mentioned?
So you can use the patient's own blood to get the serum, and you separate the serum, you centrifuge, separate the serum, and you can refrigerate it, and you can keep up to 5 to 7 days. Now, if you need a longer course, then you need to draw back blood and separate it. So I wouldn't use old serum, because again, it's a nice medium for bacterial growth, and you're not adding any preservatives into the serum. So I would do every 5 days, draw a bit of blood, separate the serum, and use it.
Any more questions from the audience? We have another question from Dr. Arundhati. How the cyclosporin is used?
So cyclosporin, as I said, it comes in ointment preparation 0.2%. So you can use up to twice a day to 3 times a day, depending on how severe the case is. Now, if it sometimes might not respond for the 0.2%, then in that case, you can get it compounded to 1% or 2%. Now, sometimes rarely with the 2%, you might get a bit of eye irritation. If that happens, then you'll have to drop the concentration a bit back. But if the cyclosporin is not working, then the second line, you need to go to the second line of tacrolimus. So yeah, cyclosporins can be used. As I said, the ointment 0.2%, which is available in the market.
Also, we are getting some thanking notes as well, Dr. Gayani, appreciating your talk. Meantime, we are getting some more interesting questions as well. So we have a question from Dr. Veerasurya. Can we use ophthalmic drops which contain castor oil for cataract?
We don't use that here in Australia. So I don't know the benefits or anything with castor oil, but we don't really use it in Australia, castor oil.
And then we have another question from Dr. Anand Power. Would you suggest Placentrix in medication of eye infection?
Again, we don't use that here in Australia. So I can't give any comments because we don't use it here.
Then we have another second question from Dr. Hasinta related to the first one that he asked about this, how to differentiate the chronic eye cases. Regarding previous question, practically some rescued patients, we cannot take a history. And you mentioned previously neurologically affected dry eyes. How can we diagnose these cases?
So, okay, so if it's neurological dry eyes, as I said, it's always an absolute sicca. So you would get a zero tear production in those patients. And if you look in carefully, you might not have a blink reflex. And also the most common other sign is the ipsilateral nostril is very dry and crusted. So you don't have any tear production, and this side, this nostril, the same sided nostril is very, very dry and crusted. So, and you have a Schirmer tear test reading of 0. So that's more than enough to diagnose neurogenic dry eyes.
And we have some more interesting questions coming on, Dr. Gayani, from Dr. Niranjala De Silva. Have you come across eye issues related to protothecosis?
Say again?
She asked, have you come across eye issues related to protothecosis? I think I pronounced it correctly.
No, I have not seen any eye conditions relating to protothecosis.
And then again, we have another question. And sometimes it's difficult to differentiate ulcers from other conditions. Can you please give more precise identification ways or methods?
So what sort of other conditions are you talking about?
Dr. Arundhati? This question is from you. If you can let us know what sort of eye conditions that you are referring to that you want to differentiate from ulcers, we'll be able to give you a better clarification. And then we have another thanking note from
Yes.
Dr. Tilak.
Sorry. If you can't come up with other eye cases that you might be wanting to differentiate with the corneal ulcers, as I said, always a corneal ulcer will be taking the fluorescein dye up. So if you do a fluorescein test, it's always going to take up the dye, because a healthy cornea, if there's no corneal defect, it's going to repel the dye because it's hydrophobic. It's a lipophilic cornea. So only if there's an insult or an eye ulcer, you would be seeing a dye uptake. So if there's a dye uptake, you've got a corneal ulcer, and you just need to differentiate whether it's a superficial corneal ulcer or is it going to land into a progress into indolent or descemetocele. So fluorescein test is the main way, but yeah, if you can come up with any other eye conditions that you are getting confused with the corneal ulcer, I can elaborate a bit, but usually if you do the fluorescein test, it's right out there.
Yeah, like you said, Dr. Gayani, the fluorescent eye test is pretty straightforward in diagnosing corneal ulcers. And then we have like some more questions coming in. I hope we have some more time to take these questions, Dr. Sicca.
Yeah, we can use few minutes. It's okay.
Okay, thank you. So do you have any suggestions for diagnosis and treatment about the corneal abscesses?
So now corneal abscesses, if you're talking about melting ulcers, now we don't really have corneal abscesses like that. So either you get progress to descemetocele, but then again, you would need to diagnose it by doing the looking at the appearance and how it's responding with the fluorescein test. If you are meaning by saying a corneal abscess is a melting ulcer, what you mean, then it's yes, aggressive antibiotic therapy and getting it under control as soon as you can. So you would be doing an cytology and culture sensitivity prior to starting the treatment, and very aggressive therapy. So the first hour, as I said, you might want to do eye drops every 5 minutes, because there's always a possibility that the eye is going to rupture. And then after the second hour, you can do once an hour. So, and with the cytology, it can guide you whether you're looking into a gram negative or rods, or whether it's a cocci. So depending on that, you can decide whether to go with gentamicin or something else. And if you have, say, if you are getting confused with lipid deposits as thinking that it's a corneal abscess, because I've never come across corneal abscesses, but you would see lipid deposits and things like that, and scar tissue formation, which do look like corneal abscesses, then you don't need to treat those. They're benign. Okay, so but abscesses, they're not going to stay there, they're going to progress, and infections are always going to end up, if you don't control it nicely, it's going to end up in a melting ulcer.
So Dr. Arundhati is again mentioning about the other eye cases like the wounds and ulcers. So I think we have answered her question clearly. And then we have another question regarding the serum treatments. So that we have Dr. Anil Kumar about the serum treatments. We at times use whole blood as injections to produce inflammatory reactions, but that helps in treatment. Do you have any comments, Dr. Gayani, about this injection?
we don't use whole blood for treatment. We separate the serum and take the serum. We don't want to cause any inflammation, any further inflammation to the eye, because there's always a risk that you're going to end up in having a severe uveitis case and losing the eye secondary to uveitis complications. So we don't use whole blood. We only use separated serum.
We will take only one or two more questions, Dr. Sugat, which is there in the chat box. So this is, I think, really important, because for most of the eye conditions, we prescribe doxycycline. So how long the oral doxycycline can be continued?
So it depends. Now, if you've got an eye ulcer and you're doing doxy, you can go for 1 week, because usually normal ulcers are healed within 5 to 6 days, and you don't need to continue more than a week with doxy in a normal ulcer. But if you've got an indolent ulcer, then yes, you can go up to a bit prolonged, up to 2 weeks. But again, when I said indolent ulcers, once you do a keratotomy, they do heal up within 7 to 10 days again. Now, depends on what you're looking at. Now, if you're looking at feline conjunctivitis, and if you're treating a case of chlamydia, then you need prolonged treatment for about 3 weeks till you get a good resolvement of the infection. Now, initially with chlamydia, so the first few days you might see it getting worse, and the veterinary nurses say, oh, this eye is getting bad, you need to enucleate, but you have to be patient, because it takes up to 3 weeks for the doxy to work and get rid of the chlamydia. So in those cases, you might want to do a prolonged doxy course, but say if it's a general superficial ulcer, just 1 week is enough. Even 5 or 6 days is enough.
Another interesting question, do we have to follow any diet changes in dogs for the corneal ulcer or abscesses?
So any dietary regulations, you mean?
Yes.
No, so they can eat the normal diet. No problems with the diet in terms of the corneal ulcers. It's just you need to keep away of any steroids orally or topically. You don't bring any steroids closer to the eye, because the eye ulcer will end up in having a melting ulcer, and then you're in trouble.
Okay, Dr. Gayani, and I think the most wanted question came last. Can you please share your presentation? That is again from the audience. They're asking whether you could share your presentation. I think it's up to you and SLVA to decide on this. So there were a lot of thanking notes, Dr. Gayani, even though I couldn't read their names one by one. There were a lot of thanking notes in the chat box. So
Dr.
with that,
Gayani, can I interrupt you? The presentation is live on YouTube channel. Anyone can go to Sri Lanka Veterinary Association YouTube channel and look at it. No need to share it. That everything is in there.
So you can access the presentation and the recording, everything through the SLVA YouTube channel. So with that, we wind up the Q&A session. Thank you very much, Dr. Gayani, for your informative and practically important talk. And also, thank you very much, Dr. Sugat, for inviting me to moderate this really wonderful talk and the discussion. Over to you, Dr. Sugat.
Thank you. Thank you, Dr. Gayani. First of all, I would like to thank our resource person today, Dr. Gayani Peiris, a general practitioner from Australia. On behalf of Sri Lanka Veterinary Association, once again, I would like to thank you for your creative, very informative and productive presentation. It's over 100 participants from Zoom link and over 50 participants from SLVA YouTube channel. So that means it's really, really grateful and informative presentation. As well as I would like to thank Dr. Gayani Peiris, senior lecturer, Kotarawala Defense University, Sri Lanka. Thank you, Dr. Gayani, for your great support to success today event. As well as I would like to thank all the participants from different region, different country in this region. And thank you very much for all your participation. And I apologize for our limitation in the Zoom link. We will definitely increase our participation capacity in the next webinar. And also, I would like to thank SLVA team for your great support to success today event. And also I would like to invite all of you to participate our next webinar next Sunday at same time, that means 1 p.m. in Sri Lankan time, endoscopy, introduction to endoscopy by Dr. Logeshwaran from London. He will conduct a very productive webinar next Sunday on 1 p.m. Sri Lanka time. So thank you very much for all your support to success today event. Thank you.